Welcome to the January 27th, 2021 webinar, Logistics and Best Practices for Billing and Coding for Telehealth. My name is Andrea Shipley and I am the project coordinator here at the Wyoming Telehealth Network. I wanted to let you know that the Wyoming Telehealth Network and our partners would like to take this opportunity to commend the Wyoming Medicaid on their progressive support of telehealth across our state. As you'll hear in the presentation, they've been pioneers in expanding telehealth services for over 10 years, and we're very well positioned to support Wyoming patients and providers during the COVID-19 pandemic. So thank you very much. I'd like to get started by introducing our facilitator and panelists. Our presenter and facilitator has 19 years of health information technology and over 30 years of general IT experience. Deb Anderson is passionate about the use of technology to help transform health. She currently consults on the CMS quality payment programs, leveraging technology and data to improve efficiency and health outcomes. Her current areas of expertise include health equity, person and family engagement, chronic disease prevention and management. Deb serves on committees for health information exchange efforts in both Wyoming and Montana, as well as working to promote and expand telehealth adoption with the Wyoming Telehealth Consortium. She serves on the board of the Montana HIMSS as the chapter president, the Wyoming Frontier Information Executive Board, the Big Sky Care Connect Executive Board, and serves on the Montana Tech Industry Advisory Board for the HIT option in the business program. Next, Lindsay Conyers is with the Wyoming Department of Health, Healthcare Financing Division. She has worked in Medicaid for almost 12 years, moving from claims and fraud review to eligibility to provider services. She has a master's of science in public health and enjoys spending her free time with her family and reading. Amy Hayes is the owner of the Office Assistant LLC and Partnered Healthcare Solutions LLC, PHS, based in Cheyenne, Wyoming. Both organizations are 100% female-owned small businesses that offer solutions to healthcare organizations that seek expertise in all aspects of revenue cycle management, in addition to offering individualized support and training in coding and documentation compliance. As an expert healthcare consultant and auditor, Amy and her team support all types of practices, facilities, and specialties to ensure revenue cycle integrity from all angles. I want to thank you all for being here today. We have a wealth of experience with us, and that you're offering our expertise and best practices to improve telehealth in Wyoming. With that, I'll pass it along to Deb Anderson to facilitate the presentation.
Thank you very much, Andrea, and welcome. We're so excited. This is your first big event with Wyoming Telehealth Network. So again, we're excited to support you and see how the changes that have occurred over the last year have really impacted our care across the continuum of care. And so first off, we'd like to start out with a poll. So I'm going to launch this poll initially and give you a little time to provide some input for us. This is going to be very helpful for us today, as well as in the future, as we are planning additional education for everyone. Or I should say, as Andrea is planning all of it, she just reaches out for help now and then, and we're super excited that you know, we're going to be able to continue this throughout the year. So thank you very much for the folks who are answering the polls. We've got about over 50% now. So it's been definitely an interesting year. We're coming hopefully to the end of a global pandemic. There are things that, as my mother would say, never expected to see in my lifetime going on right now. And so I would like to personally thank each and every one of you for your efforts, your diligence, your dedication to supporting patients and families and communities. It's definitely a trying time for all of us. So we are at 72%. I'm going to give it just another minute, not even another minute, about 10 seconds, and then I'm going to close out the poll. And then it's going to be my pleasure to hand off the presentation to our wonderful Medicaid presenter, Lindsay, who as you will be hearing later on, has been incredible to work with for most of our folks and providers as they have been setting up and billing Medicaid on telehealth services. So thank you all. Let me share the results with you. As you can see, we had some 30 folks say that they started telehealth during the pandemic, and then 94% say they plan to continue using telehealth. That's amazing, and I hope that we are seeing improved patient satisfaction and engagement with families as we're able to continue to use technology to move all of our care that's needed forward. And I think we'll still find some more innovative ways to use telehealth as we continue to look for ways to support our rural residents, frontier residents actually here in Wyoming. So again, thank you everyone for helping us with the poll information. I'm going to stop sharing that, and I'm going to go ahead and forward on to Lindsay's slide, if I can get it to go. All right, Lindsay, take it away.
Fantastic. Thank you guys so much. And it's really encouraging to see the responses to those polls. We have been super excited about everything that has come about. Maybe not so much in regards to COVID, but just sort of the strides that we've been able to make with telehealth and how Wyoming Medicaid has been able to support all of our providers through our public health emergency. Deb, if you want to go ahead and move to the next slide. Thank you very much. So as previously stated, Wyoming Medicaid has really been an advocate for telehealth services for quite some time. We actually went ahead and implemented some of our first policies in regards to telehealth back in 2007. So since that time, a majority of our claims have been for psychiatric or behavioral health services. And we really tried to work with our providers. I'm sure many of you, if you have discussed anything about telehealth with Wyoming Medicaid, you probably discussed with Dr. Bush, with our provider services unit. They have really done some great statewide Medicaid trainings with our providers to try and help explain how this technology really can be a great tool for our providers. Obviously, our collaboration with the Wyoming Telehealth Consortium and the University of Wyoming have been huge throughout all of this, and really working to help get our providers HIPAA compliant services so that they can speak with their clientele in secure manners. With this, the previous work then that we had put in has really laid a fantastic foundation for when the public health emergency came about. And we were able to just kind of step into what was already being done and making sure that if our providers needed those HIPAA compliant services, that we were able to help them get those licensing that they needed. And that way we could support their practice in the best way possible when faced with some of the most unprecedented situations that we've come across so far. Deb, if you can go ahead, next slide. See, it was working smooth the first time, but now that everybody's on, it's a little slow, but that's fine. So speaking specifically in regards to the public health emergency, we were granted some flexibilities from CMS and from the waivers so that we could help and try and support a little bit more in ways that we hadn't been able to before. Part of that was our group therapy for behavioral health clients that we are allowing between 2 to 10 clients to take part in group therapy over telehealth services. Additionally, because we understand the populations of the state and the issues, especially with our rural populations, issues with having access to Wi-Fi or internet in general, we are allowing telephonic services to be covered as part of telehealth, which normally it would not be. And really what we're looking at is any service that would normally take place in an office or be administered in that way, we are considering to be part of telehealth. The exception to that has been that we did not open up teledentistry at the beginning of the public health emergency. With that, our state has actually been fairly resilient and compared to other states in regards to dentistry. And within just a couple months after the public health emergency and the ADA saying to close offices. They were allowed to reopen some, and between 60 to 80% within a couple months had been able to bring their services and their patient populations basically almost back the whole way. So we were really lucky as a state that they were able to go ahead and basically just go back into their services as they had been within just a couple months. Some other changes that have taken place from what we had been doing before is that the consent forms for telehealth are no longer required to be completed. With that, we just need to make sure that clients are giving consent either by email, text, or verbally, and then that information is being notated in the medical records. So that's one of the biggest parts at this point in time, and one of the bigger changes that's taken place within probably the last year. So another thing that we wanted to just reiterate at this point in time, the Q3014, which will be discussed on the next slide as well as later on in the presentation, that originating site fee is not billable if the client is using their own items. So if they're on their own phones, tablets, computers, items like that, then that originating site fee is not applicable to those ones. Oh, thank you so much, Deb. You're awesome. All right. In billing for telehealth services, like we said, pretty much any service that would have been rendered in person in an office, consultations, anything like that, well, child checks that you could do, you can go ahead, the distance site can bill that with just the GT modifier. If a client is at an originating site and using the technology or the items, equipment that's provided to them, you can go ahead and bill for that site fee. And then, of course, even though we have the modifiers and these things that would kind of signal to us that it's a telehealth service, we want to make sure that all the medical records state that it's actually telehealth. And go in to give that information. So if there's ever anything that comes back, we need to ask medical records about a service, we make sure that it's all there in black and white. So, some things looking forward, CMS has come back with a lot of the flexibilities that they want to keep in place. They've realized that the services that are being done through telehealth shouldn't just be in cases of emergency. One of the great things, actually, I just saw an article today that there is a telehealth bill that Congress is going to try. They tried to pass it back in July, didn't get it through, but they're going to try again. The same legislative members who tried months ago, they're going to try and get it passed again so that we can get even more flexibilities to be permanent after the public health emergency. So we will be keeping our eyes on that and reevaluating at that point in time to see how we can best serve our providers and serve our communities. Also, a big thing that has gained traction, I came into this position as of May 1st, and as of May 1st, it has just been huge. Everyone wants to talk about it, remote patient monitoring services. And we have really been blessed that we've been able to use some of the CARES funding. Dr. Bush, again, has been a huge proponent of this and has worked really hard. And so we're looking at remote patient monitoring services, specifically with groups in regards to chronic illnesses and individuals. So like, your diabetes, congestive heart failure, things like that, but also our pregnant women, that we want to be able to provide these items to them so that they can, monitor blood pressure, fetal Doppler, things like that in their home, so that we can try to catch any potential problems before it really becomes a problem. And that way it's going to be a greater partnership between our patients and our providers to try and head off any issues if we can. So I'm sure there are probably plenty of questions, but those are all the slides I have. So I will hand it over to Amy and let her dig a little bit deeper into billing practices.
Thank you, Lindsay. I appreciate that very much. And again, I'd like to introduce Amy Hayes. Amy's my go-to billing expert. So whenever Deb doesn't have the answers, I always know who to ask. Go ahead, Amy.
Thank you, Ms. Deb. That's so nice of you. I'm going to touch on a real high level a little bit today, just talking about some of the resources that are available for coding and billing for telemedicine services. And the thing to remember on this is some of this information is driven by the pandemic. And what we've talked about historically may look different today, and at the end of the public health emergency may look different again. And so you'll hear me make comment about that as we go through this presentation. Next slide, Deb. So a lot of questions have come up about where to find information on billing for telehealth during the public health emergency. You know, one of the things is we rely a lot on the CMS website and going to those frequently asked questions and looking for those Q&A documents that give us some really clear, concise answers. The most recent website that I have posted was just updated on January 7th. We also use the HHS website a lot just because it tends to be very user-friendly and it takes us into different reimbursement and or coding information that we're also desperately looking for to make sure that we're getting clean claims out the door from the very beginning. The thing I will caution you on, though, is that not all commercial carriers are following exact CMS guidelines as it relates to telehealth services, the duration of telehealth services, and things like that. So it's really important for you to have resources and information and the ability to go out to those payer websites and find out what's actually being covered, if there are cost shares and those types of things during the public health emergency. Next slide, Deb. So what I've given on the next few slides is very specific payer website information that addresses what's going on with current telehealth coverage, modifiers, rules, place of service. And you know, we get a lot of questions about place of service and modifiers to make sure that the telehealth services are being paid properly, and you know, whether there should be a cost share to the patient and diagnosis codes and sequencing. And so each of the websites that I've given give that specific direction. So when you're getting ready to post the charges or bill your claims, verifying the payer websites is going to be vitally important. Next slide, Deb. A lot of times what you'll find is what you read on the United Healthcare website 2 weeks ago has since changed. And so as new federal mandates come out, as COVID vaccine becomes available, those types of things, those websites update on a regular basis. And so making sure that you have someone in your practice, someone in your organization, you as the provider, if you're a small solo practice, making sure that you're aware of what's being updated on those commercial payer websites is vitally important. I did not put Medicaid on here because I was relying on Lindsay's expertise, but I know that Medicaid also has a very specific link for COVID related, but they also have the provider manual as it relates to telemedicine, of course, outside of the pandemic. Next slide. Knowing your waivers is really important as well, especially if your payer mix is significant to Medicaid or Medicare, and being able to identify what services are going to be allowed telemedicine during the pandemic, but then also recognizing that those are things that you may have to go back to and evaluate once the public health emergency is decided over. Going to the payer websites, again, is vitally important. Payers have their extensions, their changes to service, their practice across state line rules, cost shares, if they allow telephone or if they require telephone and video or video with audio. So the only way we've been successful is truly going out and investing our time and looking at those payer websites to make sure that for all of our clients, we know what modifiers to place on there. We are making sure we give them feedback on the documentation and things like that. Without these websites, we would all be floundering. And quite honestly, in the first couple months of the pandemic, those rules were changing on a daily basis. The modifier requirements were changing. The place of service was changing. What was allowed was changing. And so now after 9-10 months, it's leveled off and most things are going pretty smoothly. But what tends to update is what services are covered and what cost share requirements are going to start coming back into play for the patients. Next slide. So Lindsay mentioned a little bit about site for telemedicine. And so I want to kind of touch on that. During the pandemic, the originating site opened up for patients or beneficiaries to be in their home and it still meet telehealth requirements. That has not been the case historically under telemedicine, as you all know. And so currently, a patient being at home is a qualifying site. That's something you're going to want to really pay attention to and put on your list of follow-up once the public health emergency is over, because that may not be for every payer, and it's unknown whether that's going to remain the same for under CMS and Medicaid. The distance site is where your provider is located. Of course, your clinic, your facility, at their home, wherever the provider is sitting, that's the distance site, and that's where you bill your CPT codes, not the Q code. The thing to remember is that most payers under the public health emergency still want you to bill with clinic or your face-to-face site as your place of service on your claim. So traditionally, we've billed a place of service 02 for telemedicine to indicate that, but currently under the pandemic, very, very few payers want you to use a site of service 02. So if you're seeing denials, look at your place of service on your claim, because that may be a driving force that if you've selected telemedicine, it's an incorrect site of service and they're denying it for that. Next slide, please, Deb. I found a really good resource to be able to hopefully help you all get a snapshot. This is from the American Academy of Family Practice, and we use it pretty frequently, and we go out and look for updates. But it's really an excellent resource. It gives us the information. Deb, you can advance to the next slide. They have it broken down. Let me see if I can speak. Broken down by payer. And then they also reference what place of service that payer wants, what modifiers that payer wants, if there's patient cost share involved. And the section that I put into my slide is related for COVID-19 related care. But if you go on to that website and you scroll down, it also has a section for non-COVID related care. And so it gives you specifics on modifiers, place of service, COVID and non-COVID related. So I think this is really a nice snapshot of what most payers are doing, or at least our major payers that we see. Next slide. And then last but not least, I want to kind of go back and touch on the documentation or consent for telemedicine that Lindsay mentioned earlier. We recognize that Medicaid's not requiring the formal paper consent any longer, but when you look at the commercial payer websites, there is a requirement that consent of sorts is documented in the note to identify that the service was rendered by telemedicine. And so best practice is that in provider documentation, it's noted that the visit is occurring by or through telemedicine, that verbal consent was given by the patient to have a telemedicine visit, that the modality used is documented. So are you using FaceTime? Are you using InTouch? Are you using Zoom? So that there's a reference to the type of video or audio you've used, and or documentation that you attempted to have a video conference with the patient, but you had technology challenges, those kind of things. And then documenting the patient location, and then also that the patient has been informed that this visit will be billed to their insurance if that's applicable, similar to that of a face-to-face visit. And part of that really is just understanding that the OIG just came out with their new work list, and they will start auditing telemedicine services. And so we want to be compliant. We want to make sure that the documentation we have gives a very clear picture to the payer that they've reimbursed properly. So by way of that, I think it's just really important. And for those of you, I've seen some of your names pop up and I'm very familiar with you. I just think it's so important for our providers to articulate in their note what really happened. And as part of telemedicine, part of the pandemic, this is going to be really vital as the OIG starts opening up their work plan and requesting notes and such. How are we doing, Miss Deb? Let's do our polling question, everyone. We have another one, and we think this will really help us drive some more webinars into the future. So we have another poll. Have your telehealth visits increased in the last 6 months? And has this presentation helped answer questions to resolve some billing issues? So we'll give that a couple of minutes here.
Those responses are coming in really fast, and they all look really good.
It looks like we're going to have some great questions.
Yeah, and obviously the second question speaks to how well you and Lindsay have presented the information. So I again will tell you thank you. It's always nice to have the know-who of who to get in contact with when some of this gets a little too complicated. All right, we're at 72%. If you want to take just a little bit and answer the poll, we'll give you 10 more seconds. I'm going to go ahead and get that ended here. And share the results for any of you who can't see those behind the scenes. Our result is that 82%, 32 folks have increased their telehealth visits in the last 6 months, and that we have answered some questions with this presentation that will help resolve some billing issues. So thank you so much for taking the poll and helping us with that. I'm going to go ahead and move forward to the fun slides. Now, it's not that fun because you get to look into my crystal ball. And obviously everybody knows that I don't have one. So we've got a list of questions that we're going to kind of, or topics that we're going to go through. And I encourage my presenters, Amy, Lindsay, Andrea, anybody else who is here that would like to take a little bit of time to help us talk about or address some of this information. I think that would be very much appreciated. So we talked a little bit about new legislation, and I wanted to point out the fact that there's some really nice places to go and try to see kind of a little bit of a roundup of what's going on legislatively. I wanted to share that yesterday there was an article in the Health IT News that talked about the next steps for telehealth, and it says, look to the states. Lawmakers and legislatures nationwide have introduced about 300 bills aimed at expanding access to telemedicine. There is a great rundown on the Center for Connected Healthcare Policy, and I've got a link for that on the resource slide a little bit further down. But it is amazing that there is so much activity and so much movement going on around telehealth, and I think it is incredibly important for us to make sure our voices are heard, talk about the challenges, talk about the barriers, talk about the successes. I'm hoping that the research and data that is being acquired now will show a great deal of success as we move forward, and hopefully we can make sure that the good toothpaste doesn't get put back in the tube. But obviously there's probably going to be some issues with questions and concerns. First and foremost, I continue to hear that payers are worried about fraudulent claims, and that's never going to go away. So hopefully we can find some really good ways to address that as we improve, use our improvement processes to continue to expand and support telehealth. One of the other things that, of course, I will always tell you is a barrier that we face is the broadband access in our frontier and rural communities or rural areas. So we do see a lot of additional funding coming out through CARES Act. I have some information on that if anyone would like to send me an email or ask me to share. We do have the, let's see, I believe there was somewhere in the neighborhood of 86 million approved for broadband access across the state of Wyoming in the last FCC funding cycle, and there is another 250 billion coming out fairly soon. The FCC did request some comments, public comments that closed just within the last week or two, which probably means that we'll be seeing some additional information about how they plan to distribute that funding coming out relatively shortly. So, Amy or Lindsay, do you have anything that you'd like to add on any of the topics that you're seeing here on the slide?
I was just going to mention that there was an article that came out back in August in regards to the expansion of the broadband and using CARES funding to try and get that out to our more rural communities. So I'm really excited. I think that's been something that's been a long time coming. And yeah, as difficult as this has all been, some of the really great things are coming forward, like expanding the broadband and the use of telehealth services, which previously may have been kind of secondary thoughts to a lot of people, that it's really shown how important of a tool this can be and how it really can be impactful.
You're right, Lindsay. And I think that, anytime we talk about changes in services or change in allowances, there's always going to be the mention of potential fraudulent claims. And, there are people that do break the rules. But just remember, when I talk about the OIG's work plan, they have to do this. And with the data, hopefully we figure out some ways to block those barriers so the people who have those creative minds to do fraudulent claims and all that extra time, we can put their uses to do some better things rather than that. I don't think the OIG's on a headhunt, but I do think that they're going to be looking at documentation, particularly under the dates of service for the pandemic, to make sure that some type of consent is documented and verification of the services can be made.
I would agree with that, Amy. I think given the nature of telehealth, there is that potential that it could be used incorrectly or billed for improperly. And so it's going to be really detrimental and important that all of our providers have their medical records and have the documentation that they need so that they can show and support the services that were provided.
Absolutely. And I think just to make a quick mention, you have to remember that there are some payers who didn't allow audio only or still don't allow audio only under telehealth, even though CMS, Medicaid, they're allowing telephonic only services. And so that's why it's so important to make sure that the proper consent and proper information is in the note to support the service that was billed.
I think somebody should just invent the billing easy button, and we have payer parity and standards across the board. That to me makes, total sense because we have technology that should support that. But I know I'm a dreamer. So patient satisfaction, patient engagement, hopefully we're going to see a huge improvement with some of the scores that, or the research that we're able to do. And if anybody's interested in helping out with a little bit of research, our folks At the university, the Equality State Research Network, ESRN, does a lot of pilot projects and things around what we're seeing in the communities. So I would recommend, if you have any interest in measuring possibly some of your successes, to let us know, and we'll get you in contact with those folks as well. And then I am going to spend a little bit of time on the next slide talking about the HIPAA and the secure platform issues. So you heard Amy talk about waivers. The use of chat apps like FaceTime, Messenger, Google Hangouts, those are not waivers. Those were actually a notice of enforcement discretion, and really that just tells you that the Office of Civil Rights, OCR, and Department of Health and Human Services, HHS, hey, can we do some more acronyms here, have the flexibility not to pursue action if you've used these. Now, they did definitely indicate that you should not use Facebook Live, Twitch, TikTok, and similar video communication applications that are public facing, as in I'm live streaming whatever, and hope that every provider in the universe gets to see my information. So again, we have seen the continuation, another 90-day extension for the public health emergency. We're looking at that expiring somewhere around April 21st. And this notice of enforcement discretion was also renewed. So you have time, but if you are utilizing some of these platforms and you are concerned about the appropriate use or the security around them, please feel free to reach out to the Telehealth Network or to me or anyone that can get you in contact with us, and we'll be happy to help you review and determine, potentially an appropriate platform for you to use as well. Lindsay, Amy, Andrea, want to comment on this one at all? Oh, come on. You guys don't like the geeky stuff like I do?
Love the geeky stuff. As you know, we do have HIPAA secured Zoom licenses available for providers. So I just want to make sure that everybody knows that that's a resource available to you if you find yourself in the future in need of a platform. But we're always open to discussing what best fits your needs.
And just remember, those are free licenses. Free. All right, so let's move on a little bit to remote patient monitoring. Lindsay was all excited about remote patient monitoring. So some of you may or may not know that the state of Wyoming has determined that they were going to use some CARES funding and created a Wyoming Remote Patient Monitoring Initiative. I've included the link here for providers to request devices that patients use remotely in their homes that automatically connect Bluetooth and can submit this information across the internet to a specific central dashboard for your providers to monitor and review things like your blood pressure, your weight, your temperature. I think we've got glucose monitors, we've got the blood pressure monitors. So last I heard from Dr. Bush, there may be up to 100 kits still available. So if you are interested in this application, please let us know. You should be able to click on the link once you receive the slides. The PDF version of the slides, I think, already went out. But if you didn't receive that, please reach out and let us know. We'll be happy to get that to you. And also, WyTN is sponsoring Connect America, because Connect America is the vendor that is providing these units. And that is going to be Wednesday, February 3rd from 9 to 10 a.m. And Andrea has graciously provided us with the link for those demonstrations as well. So at this point in time, I wanted to show you that here are the resources that we mentioned briefly. Obviously, you've got Wyoming Telehealth Network. Talk to them about free Zoom licenses or about any technical support you may want or need around telehealth. Also, any ideas for education, any ideas for special interest groups to talk about continued expansion of telehealth, whatever you need, reach out to them. They're always happy to help. Nationally, you have the Center for Connected Health Policy. There is their website, and there are multiple telehealth resource centers, TRCs. We actually belong, in Wyoming, belong to the Northwest Regional Telehealth Resource Center, and there is great information out there, including a link to additional telehealth funding opportunities, which I listed as a separate link. And then also I went ahead and threw in the website address for Connect America if you just want to go out and take a look at who they are and what they may do. Some of you, this probably doesn't impact, but if you're interested, there's a link for you to utilize if you want to. And then I think we'll get ready to take some of the questions. Hopefully you've put lots of questions in the chat. And Andrea, I'm going to go ahead and say that remember that your next month's webinar is February 24th, 12 to 1 p.m. And they will be revisiting billing reimbursement for telehealth with, I believe, participation from multiple payers in the state. So
That's
that
correct.
will be a great one as well.
I see that we have a few questions in the chat box. Was there somebody else who was just coming with a question?
So I see two. So let me start with what codes are people using for telephonic visits? Amy or Lindsay?
So it depends on the payer. We have telephone specific visits, the 99441 to 99443. Some payers are also allowing you to bill an office visit, even if it's telephone only. So during the public health emergency, you really have to go to the payer specific website to determine what codes they will allow you or want you to use for a telephone only visit. There's also couple codes related to virtual check-ins. Some of those require a portal, some of those are deemed telephone. And so I would really encourage you to go to the specific payer websites or shoot me an email and I'll see if I can help you navigate what you need to do if it's not one of the major payers.
Yep, and just kind of to back Amy up on that, for Medicaid, the codes that she mentioned are the same ones that we would use, of course, with the GT modifier, because at this point we are allowing to have the telephonic visits be the same as if they were doing, you know, an asynchronous visit or anything over Zoom, FaceTime, anything like that. So.
Thank you. This one must be Amy's question because it says, can you comment on the audits of Medicare Part B and how it will affect clinics?
Yeah, well, maybe. So, you know, we don't have a super clear definition yet. We just know that under the OIG 2021 work plan, they will start auditing for telehealth services. As with any audit or review, you know, if there's no malicious intent and there's no intent to defraud, what they're looking for is, does the documentation support what was billed? Is what was billed allowed under the pandemic? But then also they're looking for the consent information. It's really important that that consent information be documented in the note. Whether, you know, depending on if it's a telephone, a video with voice, how many minutes were spent, if you're using telephone codes, are the correct modifiers present? That's what they're looking for, just as if they were looking at clinic visits.
Excellent, thank you. And we did have a request for you ladies to make sure that everyone has your contact information. So I'm thinking the easiest way to do that at the moment would be to go ahead and have you put it into chat. So that's both for you, Lindsay, and you, Amy.
Sure.
Andrea, am I missing any other questions in the chat box?
I have a question. Is it okay just to unmute and ask the question?
Absolutely. That's wonderful, Terry. Thank you.
Okay, thank you. I'm just wondering in relationship to speech language pathology and speech therapy services, what is reimbursement looking like for Medicaid here in Wyoming? And also, I noticed earlier the group code that you had there. I understood that that was for behavioral. Is there a group allowance, and is that 5 for speech therapy?
I want to check and see Brenda Stout is also on the call. Brenda, I'm not sure if you want to speak about the group therapy.
So the group therapy that was listed in the presentation is for the behavioral health providers, but for speech therapy therapists out there, yeah, you can do those via telehealth, and you just use your GT modifier, and if the Q3014 applies, you can use that. And we don't have any like regulations on the group. I don't know. Do you guys do group speech therapy together?
In person, we have been allowed to use group in the past with up to 5 individuals, but and Erin Page was on the call earlier, and unfortunately she had to drop off. She helps with the university here with the speech and hearing clinic, and we provide health services through that. But the indication that we've been given is that state Medicaid is not providing reimbursement for speech therapy services. So just trying to get a clarification on that initially.
So yes, we do. You can do your speech therapy via telehealth. And why don't I put my email address, and you can send me, I don't know, I'd have to look at the codes to see about the group therapy, but we've allowed telehealth for all speech therapy.
Okay, thank you.
Thank you, Brenda.
Thank you, Terry, for the question. That was wonderful. Amy, do you see the question about the 2021 physician fee schedule, E&M codes and guidelines?
I do. So if I'm understanding the question correctly, E&M guidelines changed January 1st, 2021. So for codes 99202 through 99215, documentation and leveling, all of that through the AMA and CPT. You have to follow those guidelines when you're doing your coding. If you're asking about billing and the physician fee schedule, there shouldn't be any change other than the regular updates that they do. So I'm not sure if I understand the question other than to say during the public health emergency, if there's a waiver in place or if there's a telemedicine allowance for using an office visit code and a specific modifier or a telephonic visit and use an E&M code, as long as your documentation supports it and it's within the rules that are presented right now, you should be okay. If you can give me a specific example, because I haven't answered your question, that may help quite a bit.
Thank you, Amy. So again, if there's additional information needed on that particular question, please feel free to come off mute and talk to us, or put some more information in the chat box. Do we have any more questions? People who are happy to come out and let us hear your wonderful voices.
Deb, it looks like there's one more, and it's about consent, and it says if a client signed a consent for telehealth at their initial session and the consent covers all future telehealth sessions, will that suffice as an appropriate consent from client for telehealth services? You know, from my perspective, that's what was in place previously. I think that under the public health emergency and the requirements that are so variable across all the payers, my recommendation would be that it's in each note. I'm going to let Lindsay speak to her thoughts on that as far as Medicaid is concerned, because the paper consent requirement went away, but it still has to be documented in the notes somehow, somewhere.
And with that, I would agree. You know, if you have already previously had a signed consent form for telehealth services from that individual, that would be something that I believe that you should just be able to reference then in the medical records, that during a visit, you know, consent was obtained as of this date. And then we would know, we'd be able to reference back to that if we had to request records or any information. Same thing with a verbal consent. So if the client has emailed and or texted, verbal, whatever it may be, and you made note of it at that time during that visit, any future visits, you can say, you know, consent was given as of this date for telehealth services. And that way, again, if something were to happen, we ever have to look at the records, we're able to reference back to that and say, you know, if we need to pull additional records and say, show that the client gave consent as of that date, and then that should clear up any future issues.
Thank you, Lindsay. Do you think there will ever be, in the near future, there will be any audit guidance that potentially comes out with maybe a few more specifics on how that could work going forward? Or we just kind of have to wait and see what happens when people get audited?
I think that the first case or two is always the worst, but that's when we find out the most information. And until we get, you know, a request for an audit, or until they do one and it's not great findings, we really won't know what that all looks and feels like.
Thank you, Amy. We do have some clarification on the CMS question, and it relates to the public health emergency and home being a site for the patient, and that will continue throughout the public health emergency. So we don't know when that will end, but at this point in time, we're knowing that it's been extended through April 21st.
Right. And I think it's going to be up to the individual payers if they allow that going forward. I know Dr. Bush has always been a huge proponent that home should be a qualified site. I know how hard he's been trying to work on that. I think it's really going to be driven by the payers and what they will allow as commercial carriers, and if home's going to be an acceptable place.
And additionally, from our standpoint, a lot of it does kind of reside with CMS and what their determinations are going to be. That's part of the reason that I am really hopeful that this new legislation that is coming out federally, because that has been a big issue with using patient homes as an originating site, that there hasn't been legislative support, and there's needed to be some legislative changes so that that is allowed. And so unfortunately with that aspect, we will just have to kind of sit and see what happens with it, and fingers crossed that they really can get that corrected so that we can go ahead and keep that as an option and be able to serve those clients.
And I'm sure there will be a lot of debate going on about all of the 300 plus legislative actions that are out there. And, you know, the comment I saw was that not every bill is equally helpful. So I'm not your greatest advocate, your political advocate here, but you know, I do think that we need to let our voices be heard to make sure that the things that have worked well during this public health emergency can continue, especially to support states like Wyoming, Montana, Alaska, where we have rural and frontier populations. All right, we have a few minutes left. Do we have any additional questions?
Deb, do you see the question from Dr. Lisa Finkelstein? In Wyoming, are there any bills presented about parity?
I would have to jump out to the website, but I do not think that there was anything when I checked last.
I don't believe there is at this point.
It looks like Cheryl Foland just commented on one last week. Cheryl, do you want to unmute yourself and tell us a little bit about that?
Hello. So yes, there is a Senate bill. Let me see if I can find it. I think it's like Senate Bill 25, but it is specific to parity and telehealth. So it's probably the shortest bill I've ever seen and worked on with these committees. It's 2 pages. So, let me see if I can find that.
Great. Just in lieu of time, while we're waiting for that, Jelena Freitas has a question of who is the best person to contact for Wyoming behavioral health intervention codes?
On the Medicaid side, I would say that's probably Brenda Stout.
Thank you. Okay, I found it. It is Senate file number 52, and it is specific required parity for mental health and substance abuse use disorder insurance and telehealth.
It's only for behavioral health providers.
It is for behavioral health, but there is a companion bill that's being drafted to be presented, I believe, next week. That is specific to all insurance, not just mental health providers, but to all providers.
So Wendy and Cheryl, do you think maybe as things are introduced, you could shoot a link or something over to Sadie and Andrea at Telehealth Network and, you know, kind of give us a little synopsis of good, bad, and should we be using our voices in support of what we're seeing drafted? I would greatly appreciate that because I honestly don't have time to look every single day to see what's out there and what's changing. But we are at the top of the hour, and I'm trying to be cognizant of everyone's time. Andrea, I'm going to turn it back to you, and you can, again, give any final thoughts for today and remind folks about next month's meeting.
Yes, I want to thank everybody who was on the call today. Your work in this state is making a difference. And I don't know if you hear that enough, but we're here to support you and create a community of learning where we can all do our best practice. And so appreciate you. Would love to see your shiny faces again on February 24th of next month, where we can revisit this topic from the payers side of things. In the meantime, if you need resources, the WyTN will be launching a brand new website in February. So be sure to keep your eyes peeled for our announcements, our telenewsletter, and other resources that we can share to help you with your work. So we appreciate you deeply and hope that you have a great rest of your day.